Thank you so much, Mary. Next, I'd like to have Cathy Bradley come up. She's going to share some of her research on health insurance and cancer survivorship.
Thank you for inviting me here, and also thanks to all the patients that spoke, and especially Kim Hall, who could not have set the stage better for my talk and the kinds of things that I'm going to present. So first, just these general statistics. About 15 million survivors, about 7 million of working age. The majority are women, which is not realized. It's because we screen for breast cancer and have it detected at earlier ages. And so of those working age individuals, over half of them are women. We have a shift in stage in diagnosis, which is a shift in age in diagnosis, which is a good thing because of early detection, but it also leads to younger individuals being diagnosed and treated for cancer. So this slide shows some of the cancers that we screen for during the working age years, our most prevalent cancers. We've also had a shift in treatment to the outpatient setting. So when it goes from the inpatient setting to the outpatient setting, there's already an assumption that it must be pretty easy to handle the side effects and the things that you've got to deal with during treatment. Duration ranges from a few months to years, and now that's shifted again. So we've had treatment not only shift to outpatient, we've had it shift to oral agents now, and it continues until evidence of disease progression. So as bad as chemotherapy and those kind of things were, or radiation treatment, it did have an end date. But now that we've changed treatment, the side effects go on for very, very long periods. It's not just the late effects of treatment, but it's the ongoing treatment, duration and the treatment and side effects that come with it. And longer survival periods. So the longer you live, the longer you're in the workforce, the longer you deal with these issues. We have to think about this also in the context of what's happening in the workforce. So it's not just what's happening at treatment and the changes in treatment, but also what's going on in the American workforce as people are being diagnosed and treated. There's a tendency to remain in the workforce longer. It requires more resources to retire, and there are more women entering the workforce. So that changes the dynamic within the workforce and what happens. We have a difference in how work is being conducted in the US. For those that are high skilled, it's becoming more of what's called a gig economy. People working at home, working for multiple employers, and having lots and lots of flexibility, but virtually no benefits. So they are not then covered by the kinds of laws that have been put into place with Family Medical Leave Act or the ADA, because they work for a lot of different employers, or they work for a while and then leave. So this is changing the landscape of work itself. However, these are our skilled labor, and they can compete or work for places that have better environments and that might be more conducive to their condition. And the two top demands following pay and salary are healthcare coverage and work flexibility, the two things that employees demand. And again, this is our skilled labor. At the other end of the spectrum, and we have to think about everybody, we have a really different scenario of the low-skilled labor trends where work hours are being cut back, so people work multiple jobs. There's a withdrawal from the labor force, particularly among men. Cost cutting by removing healthcare coverage and other benefits, and if we think about the policy changes, there may be fewer options of where to get healthcare coverage. And then what used to be a middle layer of middle skilled jobs, think about a cashier, it's a repetitive job, but it's a middle level skill, that's actually going away. And there's a shift where women are actually moving to the more higher skilled and men to lower skill. So a real difference in how the workforce is changing, and then that's going to shape what happens to cancer survivors as they try to continue within this new kind of workforce. Lots of motivations to remain working, health insurance being at the top of that list, wages to combat financial toxicity, which only gets way worse if you lose your health insurance. It's bad enough with it, much worse without it. Reduced household income, And then this idea of sense of normalcy. So while we have good measures on quality of life, what really sends a signal to our friends, our family, is when somebody says, well, how is he doing? And the answer is, he's back to work. So that immediately signals something in our mind about recovery and how someone is doing. So this is a key marker, yet it's not included in any clinical trials or how we study drugs as to whether or not that person can go to work after they've been treated, or what kind of side effects they'll have that will impact their ability to work. We think about patient decision making, we'd want to know if getting chemotherapy is going to be worth the trade-off in terms of the benefit it provides and our ability to continue functioning. Outcomes that have been studied in this area is something economists call labor supply, simply whether or not you work and how many hours a week you work for both the patient and the spouse, although very little done on the spouse. Wages, your ability to maintain your benefits, and whether there's something called an hours lock that I'll explain in just a bit. Job mobility, whether or not you're able to move jobs once you've been employed. Do you stay at an employer after having been diagnosed and treated? And work limitations. Mediators in all of these studies for those particular outcomes are the type of treatment that you get, the dose of that treatment, and the duration. I've seen in my studies, the longer the treatment goes on, the harder the time the individual is coping with it. After a while, everyone is tired of having had treatment, and then the side effects start to accumulate, employers become less understanding, and the problems start to rise. Symptoms, the interference of those symptoms, and functional status. And again, this goes back to a measurement. We want good symptom control. How do we do a good job of symptom control in a way that doesn't further interfere with work? And then functional status, can you continue to do what you've been doing? Education is a big mediator. Those who are better educated do better. Work site conditions, what kind of job tasks do you have, the willingness of your employer to accommodate, and what kind of accommodations do they provide. Health-centeredness or well-being environment, and this is becoming a new area of research. The CDC funded some centers called the Total Worker Health, and to look at the centeredness of a work site and their knowledge and understanding of worker well-being and how to promote that and to make a business case for doing that. As you might imagine, larger employers embrace this concept. Smaller ones, it's very, very expensive, but many of them want to still make an environment that is compatible to well-being. And I think an exciting area for research that we have to do a lot more is the kind of education of employers of what it means to be a cancer survivor. Supportiveness of the work environment, and then job satisfaction. In my studies, people who start off with low job satisfaction, there's nothing about being diagnosed and treated for cancer that improves that situation. So those things tend to actually get much, much worse. And poor job satisfaction was correlated with outcomes. Having very low quality of life, high depression and anxiety symptoms was correlated with having low job satisfaction prior to the start of treatment. So work has a huge impact on our well-being and how we're doing. In my studies of breast and prostate cancer, we see, not surprisingly, the lowest participation in employment and hours worked during the treatment. Then there's a bump up. At about 12 to 18 months, we see people going back to work and doing okay, but then it goes back down again. 2 to 5 years, and if you were to trace the line out more, you would see that individuals start to drop out. However, the paradox here is that those who continue to work more hours. And that's related to health insurance, because there's usually a threshold at which individuals can continue to carry insurance. These studies were done prior to oral agents. The literature has not caught up to the new therapies that are now available. The risk are chemotherapy for treatment, extended treatment, fatigue and depression, functional limitations, and compromised cognitive functioning. We found that women who were higher educated in these cognitively demanding jobs that had been treated for breast cancer for long periods of time tended to suffer the most depression and anxiety, largely because they had intensive jobs that they were highly invested in and unable to perform them. And it would be interesting to have been able to incorporate those kind of symptoms and outcomes into a patient decision-making process. But work is not part of that at this time. The negative work environment, few accommodations during and following treatment, unsupportive supervisors and coworkers, these are all things that are guaranteed to have a poor outcome for a cancer survivor in the workforce, and also physically demanding jobs. And then there are patient characteristics, older age, minority race and ethnicity, and poor physical functioning, late stage of diagnosis, that are predictors of poor outcomes. This is a list of some of the physical functioning problems that we saw after having studied both prostate and breast cancer survivors. Nearly half of women with breast cancer found that cancer and its treatment interfered with their ability to do physical labor. We also see high levels of poor concentration, the ability to do analysis, keeping the pace set by others, and learning new things. All were affected. So accommodations, huge role that the employer has in being able to accommodate a cancer survivor. In the studies that I've done, I find that in general, 87% of a predominantly white, well-educated sample reports have an accommodating employer. We don't see that in low-income workers. So I started off with the context of the American workforce changing, that what we have is this difference between these very high-skilled workers that can compete for jobs on wellness-centered environments, and low-skilled workers where we're getting just the opposite, where they're cutting back on benefits and cutting back on hours worked. That's not where you're as likely to see accommodating employers. And in a study recently published in Health Affairs by Blender et al., low-income, multi-ethnic women were less likely to have an accommodating employer relative to this 87% of a predominantly white, well-educated sample. There have been very few studies on spouse employment, and what we found is that employed spouses of women with breast cancer do not change their labor supply. They tend to continue working, largely because women can draw from other types of caregivers. Whereas when men are ill, women, their wives tend to be their caregiver. We did see some decrease in employment and hours work only during the active treatment period, and we saw men who insured their wives, who had a family policy and they were the policy holder, tended to decrease their hours by less. So they worked more hours in order to preserve health insurance. So these are the trade-offs that individuals are making. We find that those who have the family policy are more likely to work than to provide caregiving. Those who carry the insurance themselves and they are the cancer patient and survivor, they're more likely to work as well. So these are the kinds of comparisons to really understand this. And it has tremendous policy relevance as we debate what to do going forward with health insurance. I looked at these different groups of having health insurance by your job, having the offer, meaning I don't have it, but I could get it, having a spouse with insurance, and then having a spouse with an offer of insurance. And you could think about different health insurance reform scenarios where this would fit, the ability to get it. Can I go out and buy health insurance versus this is the only way I'm getting it through my job? And what we found was that hours worked, there was an 8 to an 11% difference in hours worked. In other words, in hours locked. Those who had health insurance through their employer kept working no matter what. And when we studied in women, and I recorded all of the interviews that we did, and we've done over 1,200 of them, and gone back and listened to them, they would miss a chemotherapy appointment before they would jeopardize their work because if health insurance was tied to it. And if there were also dependents, if they had kids and a spouse that was connected to their policy, they just simply didn't miss work. They found a way to work in their treatment around it. And the evidence got more and more strong as we get down to women who had no other offer, no spouse with insurance, no other way to get it. They were solely dependent on their job for health insurance. So a big implication as we think about moving forward with the ability to get health insurance outside of the work environment. So this dependency on the employer for health insurance may result in loss of coverage for those who cannot continue working. So while everybody tries to, not everyone can, and that does jeopardize their ability to get health insurance. Employer-based health insurance may be associated with health sacrifices. So the study that you do for those that continued working, no matter what, is at what cost? What were the long-term outcome of making that, instead of recovering, but making that sacrifice? And it suggests, though, that having an alternative, just by having the option to get insurance outside of the work market, doesn't lead to a mass exodus. So there's some belief that, well, as soon as individuals have health insurance outside of the employment area, they get sick, they're going to quit. That wasn't the case either. And we could test each of those kind of scenarios with the study that we sampled. But we do know, with the threat of losing health insurance, they continue to work. So there are implications of this research for both clinical, the work site, and the policy level. At the clinical level, I think outcomes need to be part of clinical studies. What's the impact of different kinds of treatment on one's ability to work? And this is a really big deal beyond just the subjective quality of life. What are the measures? What happens within a new treatment that impacts work, and how, especially if you're going to take it until there's evidence of disease progression. Better symptom control, and the things that you do to control symptoms shouldn't make other things worse. So if you're giving a drug to help with insomnia and it makes you sleepy at work all day, you may not have solved the problem. But to think about it in the context of what this person is doing and going to work. At the workplace, Ms. Hall mentioned that workers, employers don't understand the long-term effects of cancer and what it really means to be a cancer survivor and to go forward, how long it takes beyond the active treatment period. That's absolutely true. We need to think about educating employers. There have been very few workplace interventions, and a lot more needs to be done. We certify now, thanks to the CDC and the Total Worker Health, certify employers for being a healthy workplace or a work-centered environment. Part of that needs to be cancer survivorship. 15 million survivors, 7 million in the workforce. That's going to continue to rise. We need to educate employers so that they can do a better job of caring and providing the kind of accommodations that survivors need. The accommodations that we heard most often were needed was flexible schedule, reduced hours during active treatment, and special equipment for workers. And special equipment really stumped us. On the study team, we kept thinking, what on earth could they be wanting? And this was a sample of breast cancer survivors. Again, went back and listened to the recordings. Special equipment was a laptop and computer so they could work at home. Huge difference that would make. Every employer has a closet full of old laptops. What a difference it would have made to be able to get that kind of accommodation. It's really that simple. And then at the policy level, options for health insurance outside of the workplace, and then repeatedly paid sick leave. We do have Family Medical Leave Act for the part of the workforce that is eligible for it, but remember that act does not apply to small employers. Most of our workforce is employed by small employers, and now more so becoming independent contract type employees as they move around. Paid sick leave is a really big deal as to whether or not they can continue to be tied to their jobs and to their treatment at the same time. And this is critical as we think about the changes in the American workforce, the shift to a gig economy, the disappearance of middle-skilled labor, and then the low-skilled workers, and how things are changing at both ends of this spectrum, and being able to think about solutions that works across that spectrum. Thank you.